Many thanks, Claire, for the introduction, and many thanks to the organisers for all the work that's gone into this. And Sally, a number of things. I haven't been to all of the 40 CASIs, of course, but I have been to quite a few of them. I don't know if I've spoken at that many of them, in fact. So this is a novelty to me. As Claire mentioned, I'm going to talk a little bit about COVID, but I'm going to talk also about data science versus statistics, which is another issue that perhaps Sally raised. And that's the question that for the last few years I've been wrestling with, even though we have got a big training group between UCD, Maynooth and Limerick, where we're training PhD students in the foundations of data science. I've always felt that perhaps we've gone too far in popularizing data science at the cost of what I would say is statistical thinking. So I'll focus a little bit on that. And Claire mentioned that we're involved in IMAG, and a few weeks ago there was an article in the Irish Times by Peter Lynch from UCD, who covered the benefit of mathematical modelling and statistics working together. So Brendan as mentioned in the article, was interviewed, and James Gleeson from UL. Brendan had texted me one morning on a Sunday morning in March, and it was my understanding that the CMO had been looking for help with this modelling side, and subsequently Philip Nolan, that's not me in the bottom left, so Philip Nolan chairs the committee, and so he had organised the group of us together from a number of different universities and a number of different backgrounds, and a number of people are on the call here. I should acknowledge as well that there's been a much broader group than just the IMAG group itself involved, Claire being one of them, and colleagues in both UCD and UL, as well as others in Maynooth. Well, the promise of data science, as I saw it certainly in maybe in recent years or recent decades, was that now with N being all, so that we collect so much data, we perhaps don't need to worry about statistics anymore. We don't have to consider the question of the models that we use to the same extent that we might have. Maybe our inferences are model free now. We'll allow the data to guide us, so we don't have to think about the utilities to the same extent. The data will tell us everything. And decision making will be automated. So we mightn't even need people anymore. We see this as a promise with strong AI and driverless cars and so on, that we can improve things by just allowing the data, the computation to take over. On the flip side, of course, we have then statistics, which very often focuses on small or relatively small data problems, and relatively small data problems could be quite large indeed, but still smaller than this N equals all. Often we're looking just at a sample. I would argue that model is always required when we're doing statistics. So we might say that our inferences may be model independent, but underlying it all, certainly in a Bayesian setting, we think of this model that's lurking somewhere, even if it's not explicit. Instead of the data guiding us, we might have to take an uncertain path around it all, so that we're not directed solely by data. We might have so much uncertainty left, residual uncertainty in our inferences, that we can't really automate this decision making. We can only summarize the information that's in front of us in the context of a model. And we now, as statisticians, are getting our P45. So that's us out of a job. I'm not even sure if P45s exist anymore, but they did until the revenue automated their systems to such an extent that now they know every week what we get paid. The magic of data science, of course, we see it in all the apps that are out there, and apps is a topical subject at the moment, and I shan't discuss explicitly the app that we're looking at for tracing, but apps for other things. So apps might tell us when our favorite stores are busy. Now, of course, at present, those blue bars at the top left there, they may be all zero. Well, they're growing now again, but for a period they were zero. Google used to tell us less busy than usual for a long time, a lot less busy than usual, busier than usual, and also helpfully advise us that opening times might have changed due to COVID-19. So that's the information that we got from the Google apps. Google Maps would tell us about the traffic jams that were up ahead of us. Great facility. So that if we find that there's a traffic jam on the motorway between Limerick and Dublin, then we can go through the town to avoid it or take a different route. Bump is an app for identifying potholes in cities. So everyone runs this app, and when they drive over a pothole, the phone vibrates and sends a notification, and the county council then can go and fix the potholes. So this is a great idea. We don't have to send people out inspecting the roads anymore, testing the roads, looking for potholes, and there's an analogy there, of course. No, because the app will do it automatically for us and identify where the potholes themselves are. From about a decade ago now, there was a piece in Nature about Google flu trends. So magic of magics, by using our search engine history and the search terms that were used, we could identify where flu was going to break out before the CDC knew. So we could use technology to preempt the traditional public health work that was out there. Well, in contrast, statistics and modeling, of course, concerned themselves with taking samples. You know, there was this whole idea: how do you select a sample? Do you do it at random? What do you do? With models, so the model is a lens through which we look at data, and you could look at many different models. So the two different models illustrated there, for example, and they could be statistical models or they could be mathematical models. Data being X on the right-hand side, and our inferences on the left there being parameter estimates, let's say, or even indeed it could be a question of model choice. Which model do I use? Conditional on data that I've collected. Experimental design is in the bailiwick of statisticians. Who do I select from the sample? What do I collect data on? Evidence synthesis is, again, an area that certainly I've worked in, so be it meta-analysis, but we can think of it as the integration of information from multiple sources, perhaps different parameters, and perhaps the same experiment or similar experiments, and we can do inference then about should we license a drug, should we use face masks, for example, information brought together from multiple sources of perhaps different quality. Well, the promise of data science in the context of COVID became the question about the promises of data. So rule zero is you can't get it. And a number of other people on the call, I know I've spoken to over the last couple of months, have been so frustrated with the fact that the data were so hard to get. Rule one then is even perfect data are not going to be enough to answer some questions, and we'll illustrate why. Rule two, the data are not what you think, and the data are wrong anyway. So is this hopeless? Is this hopeless for data science? Well, what do I mean by these anyhow? Well, here's the way that we actually could get reasonably good data, and that's to become an officer of statistics. Coordinated Sally-Event official statistics, an extremely important group across society, I think, and it is a solution to the question of access to microdata when it's needed. In the context of COVID-19, we had to become officers of statistics, and you log on remotely to the CSO desktop, and it's a restricted desktop. Access is very limited to the people that signed up. We had the presidents of the universities to sign off on our access to the data, each of them on behalf of our institutions. The other source of data, and the data that's feeding into the CSO system, comes from CIDR. And CIDR is the computerized infectious disease recording or reporting system. And so that's hosted by the HPSC. It's connected into the hospitals and into the intensive care units across the country. It has limitations, and that's why I say limited as well. So the access we had was limited. It was anonymized. We didn't have spatial information. We did know something of the unique. There were unique identifiers, but they weren't. They didn't disclose information about the individual. The data from CIDR was uploaded with delay, so it had to be uploaded from the hospital systems, and even a day or two delay could be a significant delay in the context of this disease. Remember, doubling of cases happened every 3 days, and so 2-day delay is a substantial delay. Cases will almost have doubled by the time you get data on the cases that are in ICU to the detail that we wanted. So here's the frustration, and thanks to call out Andrew Parnell in Maynooth for dealing with the messy data that was publicly available from the Department of Health website in text format like this. Didn't always appear to be consistent. There were changes, denotifications, for example, changes in numbers, and so it was a challenge to bring this all together. Even the meaning of some of the fields and the accuracy of some of the fields weren't perfect, but that's because they're collected by people, and people might misenter at a local centre the data, and so it doesn't represent what we thought it was. The other group that brought this together were groups in Limerick. I know the COVID Watch was managed by Liam Glynn, who's general practitioner, professor of general practice in Limerick, and Len Brown as well was involved in bringing together some of the data too. Well, why are the data not enough? Sally would hate this graph. I did comment on the PM's graph, of course, as well, as Twitter knows. So the same graph as Sally showed, but this one doesn't have my axes, except time goes from left to right. The horizontal location doesn't matter, the vertical location doesn't matter. The first dot is a first case, second dot is a second case, third dot another case, and so on. And this is typical of the information that we get for notifications of cases, or we'd like to get this information, which is maybe the infection event, or it could be the reporting event. Joining these together from contact tracing, for example, we might say that the first dot is connected to the second dot, and so the second dot then we know is a secondary case from the first primary. The third dot is a secondary case of the first primary. The third dot in also happens to be a secondary case of the first primary, and so on. But that's not the only way that these dots could be connected, and even with the information that we have, it mightn't be the only way that they could be connected. There may be other ways, even given the fact, because of the exposure, people might have been in the same place, they might be in the same household, and so we might connect the dots differently. And this is the challenge of identifiability. So I'm showing the same data, the same dots, connected in different ways. And the question is that we all want to know is, what is OR? We've got to know what this means recently. There is another parameter though, and that's called the serial interval, or the generation time, which are related. Generation time being between infection, serial interval being between when cases present. Well, it happens that we highlight the pictures like this, or the possible connections like this. Well, here you've got a primary infecting 2 secondary cases, and in fact then the next dot along is infected in the top right, is infected by that secondary case. And so in the first case here, the value of OR is 2, so each case is infecting 2 other cases. Whereas in the bottom diagram, OR is 4, so each case is infecting 4 cases. So the data are compatible with both those situations. So formally, this is called identifiability. Sally mentioned survival analysis, and this is a classic case of censoring as well. So the challenge we have here is that we may know something about the fact that an individual was infected by such and such a time because they developed symptoms, but not when they weren't, in fact, if you like. So it could have been any time before a certain time. So we've got censoring in that. Typically, it's interval censoring. We know they weren't infected a week ago, and we know now that they are. There were multiple possible infection events, and so we can't actually identify which of these situations we're in. So either OR is 2 or it's 4, given the same data. And the serial generation time is either fast or it's slow. In other words, the time between when an individual first case and subsequent cases are infected could be long in the case of OR being 4. And they're both compatible with the same data. So the data in this case are not enough. We have to find another method of getting at the serial interval if we're going to find out what OR is. The data are not what you think. So this is from Worldometer's data. And is any of this data accurate? Well, probably not. Population seems very exact on the right-hand side. So even data that we should know seems very, very exact. We know from coverage elsewhere that the number of deaths is something that is reported differently in different countries. We know that the total number of cases is subject to ascertainment bias. How many tests did we do? Well, they've started to report this as well, which is great. But is that figure for testing accurate? And if you're a fan of more or less the Radio 4 program, we've had a number of episodes recently on what is the testing data mean in the UK? What's the definition of death in the UK? So the data, in any case, aren't what you think. Even the notifications that we get, for example, aren't what we think. What we'd like to know about is when the infection occurs. So that's what we want. Onset of symptoms, and another project that we're working on at the moment, and for years I worked with equine influenza, but it's about when did influenza get into a horse yard, and that's not just the subjective reporting of the horse, of course. In that case, it's a subjective reporting of the trainer, who might or may not be as alert to their animal welfare as other yards. When was the sample requested? So the diagnostic sample requested. That's another date that we have, and we can get that in fact from the system, and so we've been using that for much of the work, because it's an objective, if you like, time. And then the time to confirmation, and we hope that the delay between the sample being requested and confirmation is short, and that's the public report that we get. So that's the data that we actually get. So the data that we get every evening isn't what naively we might have thought it was. It's certainly not the number of infections occurring that day. Those infections have occurred sometime in the past. And in principle, we have a distribution, so a time distribution. So this is the proportion reporting, if you like. So it goes from when you're infected at the left-hand side to the proportion, and eventually then all of them get symptoms. Although it's not quite accurate, but these are conditional on the fact that they will become symptomatic. And then this is the time of confirmation of diagnosis. And from international data that was well modeled by a gamma distribution, although the chair of the conference, so Adele, will know that gamma distribution probably doesn't fit these data well, and you're quite right. And so there's a bit of work to do yet to find out, to get better models for this time to notification or time to reporting. But in the context of the Irish data, we had something even more complex. So this is wrong for two reasons. So theoretically, in fact, it's going to be wrong, as Del will know. But also, on the right-hand side here, we see a histogram of the time, and this was at day 35 or so. This is if you take the day of testing request versus the day of reporting, then by day 35 onwards, we get this bimodality, or we got this bimodality in the Irish data, for the simple reason that some of the tests were queued up and had to go off to Germany to be reported. So we got some tests that were tested locally when the capacity improved in the MVRL, and then some that were tested much later. And that's certainly not a gamma distribution. It's bimodal. So not only is it not the data aren't what we think they are, they're not what we could derive from experience elsewhere. So it's more complicated than we had imagined. The data arrived late is another point, and the reason that, again, as a quoted statistic, Germany versus the UK, Germany doing better in terms of total number of deaths. Lockdown in real terms was about only a week in the difference, but with a doubling time of 3 days, every 3 days, the number of infections doubling. A week is 4 times the infection, and 4 times the number of deaths were seen in the UK. So from an epi perspective, Germany locked down about a week earlier and saved 75% of lives that could have been saved in the UK. But let's not blame people, because it's a difficult call. When we're at about 100 days, and we decided to lock down at about 100, we closed the schools at about 112 days. I'm using 100 as the end of February, start of March, because of the way the data fell in Ireland. That at the stage when we were seeing even 50 cases, the true number of infections in the community or true number of reportable infections will be about 250. And there's a piece by Sheila Bird in The Guardian, I think David Spiegelhalter tweeted it as well, where she refers to this phenomenon as well. So locking down early at the slightest sign on the upswing is vitally important. But when we're falling as well, and people are wondering, why haven't we seen a second wave? Why haven't we seen a large number of cases given people mingling and so on? Well, the force of infection actually falls off before the reporting of the cases. So by the time we've even got a modest number of cases being reported day to day, the force of infection has got so much very low, much lower because of this lag, because the data arrive late. And the data are wrong. So we know when we see data like this, and this is from the IHME model, and it's the internationally collated data, we know, and this is the data for Ireland, we see spikes like this. This is reporting bias. We see active cases going down in this fashion here. Well, it looks like it's press refresh every week and take out some cases. So we've got incorrect data as well that are in there. And even the tests are imperfect, I would say. If you're just infected, the chance you'll test negative. So this is on the left-hand side, the probability you'll test negative, given that you've got disease. Days going from left to right. Day 0 of infection, you're going to test negative. So should you test people coming into the airports? Well, if they've been infected on the plane, they're going to test negative. And even if you test them 24 hours later, they're going to test negative. Or 48 hours later, they're going to test negative. So it's not until a few days later that we've got a decent chance of picking them up. So this is lowest probability of being negative, given that you've got disease, but it's still about 25%. Why would it be wrong? Well, we know the physical process, the experiment by which we obtain viral samples is imperfect. So testing is imperfect. And it's something statisticians are well aware of. As well as the data then, I think models are key. And instead of living in a model-free world, like what we'd want to get to if we've loads of data and data are more important than the model, I think models are critically important. Some observations. You don't need data to try out your model. You can play with models without data. You can play with models with pseudo data, simulated data, and see how they behave, get a feel for them. Most models are not as good as I think they are. Many are much more sensitive than you might imagine, and we underestimate the sensitivity of our models sometimes. And some are too complex to be useful. So the question of agent-based models was raised a couple of times in the group, but having used agent-based models as well as cohort models, they're often much more complex than you can parameterize. And the variability between them is such that it makes them difficult to understand and difficult to communicate. Well, here's an example of a simple data-free model that I played with in the early days, and this was before I got the text message on a Sunday morning. I'd given a talk. We were aware of infection course in China. I'd given a talk in the RCSI in February. We knew at that stage that it looked like we were going to have challenges. And these are very simple simulations. Simulate a cohort of 10,000 individuals, infect about 100 of them, and then each of them meets varying a mean number of contacts. So simulate 5 contacts, let's say, mean of 5, distribution with a mean of 5, pick out some contacts and with some probability infect them. And then the next step of your model is to do it again for all the infected people and so on. And this wasn't a complex model. We didn't allow for the incubation period or anything like that. But it was quite clear at an early stage that for low numbers of contacts, even for a given infection rate, probability of infection given that you've had a contact, you get many fewer cases for a lower number of contacts. And it makes sense. But what really struck me as troublesome was the spike here for even a modest increase in the number of contacts. That we were looking at models that had about 12% of the population infected, of the population. So they're very large numbers. Well, we all have seen this curve now in the bottom left, flattening the curve. It's exactly what it's doing. It's moving from the simple model on the right to the simple model on the left. Reduced contacts, and therefore fewer total number of cases. And the area under the curve actually is smaller as well. So this was used in conjunction with the university, members of the university in Limerick. They sent out an email saying, if you feel sick, stay at home. Well, it was clear even at that early stage that there was pre-symptomatic transmission. So in other words, people without symptoms, before they have developed symptoms, can transmit the infection. And therefore, reducing the number of effective contacts, keeping your distance even at meetings in work, was something I recommended, and university advice was changed on the basis of that. And as we now know, this physical distance is mandated in general. Talking about models not being as good as they claimed, here's the IHME model from University of Washington, and the front of the Irish Times. My daughter was delighted to see this. So the infection peak has passed, and we're only going to have 400 deaths by the end of May, from the US model. Well, the model wasn't as good as it claimed, and that was partly due to the data that was coming in, but sensitivity as well that we'll see in a second. There's the 400 number. By May, it had 3 times that number of deaths we'd seen, partly due to the accumulation of clusters and deaths associated with clusters. There's an aside here, and that's the ethical questions that arise for both modelers and reporters. If I'm running a model, and to be fair to the IHME, they did caveat their model outputs, but if I'm running a model, I have at least some responsibility for how others pick it up and use it. So I should be cognizant of that when I present my results and make them available. But certainly experienced reporters like the one in the Irish Times should be aware that stories like this can have an impact. Either people become elated because of the positive news that the peak has passed, and this was a constant question during the epidemic. And as modelers, we know, well, it's very difficult to say at the time whether the peak has passed or not. We almost certainly can't tell. But it was a constant question. Or it may change people's behavior. So people might go out and party, which arguably is happening now. But to be fair to the IHME, on the left-hand side, the uncertainty was captured in their predictions, and that's from the time of the Irish Times article. Well, the reason that the IHME model of then, and it has changed 3 times since, was so sensitive to the data that were coming in is because S-curves in general, and credit here to Charlotte Crozier for a PhD student in Cambridge who has an animation on her website. And this shows that when you're fitting an S-curve in general, that your data, as you accumulate data over time, the predictions, which is the red line, can be very far from the true cases that evolve, being the black line. So you can be very wrong in the early stages of an epidemic. So the reason that the prediction was wrong is because it was almost guaranteed to be wrong, and because it was so sensitive to the number of cases as they accumulated. Or the models could be too complex. I won't dwell long on this one, but there are a couple of models from Imperial, and one of them was seen as totally unreliable and a buggy mess, although recent reports are much more positive once the code had been cleaned up. We all know if we're asked to produce or present our code, computer code, certainly me, then mightn't live up to the expectations of many computer scientists that I know. But the code was cleaned up and then made available and has received much more positive reports. An article that we wrote a couple of years ago looking at human papillomavirus and looking at agent-based models, as well as other type of models, showed that there's a lot of variability between model outputs, especially as you increase the complexity of the model. You get more variability, in part because the parameterization of the models are complex business. Sally mentioned Dennis Lindley. He quoted, of course, from Savage in a paper in 2000 on the philosophy of statistics, that our models should be as big as an elephant, and then we compute with the model. But the important point there is that the key features should be in your model. So we should encapsulate the infection curve, or this beta function, as it is in the model that we've used. Here on the right, we show the true situation of cases of close contacts and casual contacts accruing, the true beta function. We all have our own personal beta. At the bottom then is the modeled value of beta. And this modeled value of beta can be changed due to asymptomatic cases, for example, of a lower value of beta, and or is the integral of this curve. So the personal or, if you like, is your own integral. If you wear a mask, the question is, do you reduce it even further? Symptomatic isolation, so if you isolate cases, once they become symptomatic, they've had pre-symptomatic transmission, but after that you delete that curve. If you wear a mask, can you do even better? And in the original case, of course, social distancing just decreases the height of this curve. And so we can think in very concrete model terms about what the inputs to the model are in terms of public health policies. Conceptual diagram, it's available on the Department of Health website. That's the conceptual diagram of the Irish model, schematically on the right-hand side, shown by the one of the French models, just having different phases from being susceptible to exposed through to being hospitalized, ICU, or removed, recovered. There are other statistical issues then that I'd note at this stage, because I'm conscious of time. I'm just about up in terms of the 30 minutes, that what we do well as statisticians, I'd argue, is that we have honest, or try to be honest, in terms of our uncertainty quantification, especially in the context of complex models. So model and structural uncertainty in the models, for example, is key here as well. We know about ascertainment bias. The fact we've tested at different rates tells us what we'll find at different rates. And this came up among statisticians at discussions at IMAC. Sampling variability, when we've small numbers, we might see bumps up and down, and they may not be something to worry about. So one case in Sligo in and of itself may not be something to worry about, but it is obviously something that we'll have to keep an eye on. We know that evidence that hasn't come from a randomized controlled trial is of a different quality and should be treated differently. We know about meta-analysis. So when we're bringing data from multiple studies together, like in the case of face coverings and face masks, we have methodology to do that. For the tests, the new tests, the emerging tests, we know about their characteristics. That's something where statisticians come in. But we see also the value of proxies, and I mentioned Seamus Coffey's work on RIP.ie for excess mortality has been one that I've kept an eye on. It is a proxy, but actually I think it's quite a reasonable one to keep an eye on. And he knows himself that there are limitations and has highlighted that. Well, the reality of data science now, almost to conclude, there's built-in bias in what's being sampled in these cases. Of course, they're the people with phones. They're the people who can afford to drive around with their phone in their car, perhaps their smartphone in their car. And we know that the flu trends data had been become useless even a couple of years after the model had been fitted and tried and trusted and used. And the reason for that is that the underlying situation had changed, the way people search and so on, the devices they use. And so there's a notion, something called boiled frog syndrome. If you put a frog in cold water and heat it gradually, the frog will boil to death. The same happens with our predictive models. Unless we keep updating them and are aware of if our assumptions change, then we will suffer, our models will suffer from this boiled model syndrome. Well, the magic, to conclude, of statistics with modeling is this. We can know stuff without seeing it. And this is Dominic's hand. And how many pieces of orange are there? Well, we use logic to deduce something about the structure here. How do you cut open an orange and so on? Count the pieces of orange there. So we see 7 pieces of orange. So we might say our data say there are 7 pieces of orange. But the magic is that we can know how many pieces there are without seeing the bit that's missing, a bit like excess mortality. And the good news was that it was found, and as users of Twitter might know, I didn't pick it up, unfortunately. So that piece of orange stayed there for a couple of days. Okay, well, thanks very much.